Hello, this is Professor Lisa McBride. I'm talking to you today about the week 6 NUR fluid and electrolyte presentation. Um, this is my second attempt at this, so we're hoping that we'll get this one where it will be of a good recording for you so that you can follow along. I have already sent out a copy of the original PowerPoint that I use with my notes all attached so that you can follow along. I will be sending you 3 YouTube URLs that are embedded in this particular presentation. In the classroom, I'll be showing these, but for some reason the audio is not very good, and I don't want to waste your time with bad audio. So I want you to go on and watch these after the presentation, or you can flip through your PowerPoints at the point where that presentation would be. I believe those links should work with the PowerPoint I sent out to you, and if they don't, I'll be sending them separately in the email that I send you with this video. So please follow along, open up your PowerPoint, take notes. If you have any questions or concerns, don't hesitate to get a hold of me this week at class. We were in the classroom Monday, Wednesday, Thursday, and Friday. Don't forget that you have a quiz in lab this week, and since I'm talking to Group A that has lecture on Tuesday, that's the reason why I'm sending out this particular video. This is up to you to watch and to replace the lecture that you would have normally had on Tuesday. So we're talking again, fluid and electrolyte balance. We're going to be talking about the focused assessment for that fluid and electrolyte. And whenever we have an older client, especially that is confused, we should be considering, is their electrolytes off? Are they dehydrated? Are they, again, we always talk about, do they have a UTI? Do they have something going on? Are they imbalanced? Is something off? Is their sodium too high, too low? Because that can cause confusion and mental issues, as well as their potassium being too high and too low. And remember, potassium, if it's either too high or too low, that can be life-threatening. If it's above 6, 7, or 8, the higher it goes, the more likelihood that that person's going to experience a bad outcome. If we don't get it below that 5.0 level and get it back into balance, they can have dysrhythmias and their heart can actually stop. If it's too low, below 2.0, I have seen patients reach that low, but we don't want them to get there. If they do, then their heart could possibly stop. So very important for us to be paying attention to our blood work. And then if we suspect something is off, to also contact our RN manager or the provider and get it checked out, because your suspicions are good. Use your intuition. So our focused assessment for fluid and electrolytes is going to be done whenever we have a patient that comes into our care that has had a history of vomiting, diarrhea, high fever, history of heart failure, diabetes, kidney disease. If they've had a head injury or if they've had a fall, look at the possibility that they may be dehydrated. If they have thyroid disease, adrenal disease, or inflammatory bowel disease, whether it's constipation or diarrhea, all of these can lead to some level of fluid abnormality. Go to the next page with our next slide here, and if I can get my system here to work, will be good. Okay, the definition and scope of fluid and electrolytes. Fluid is the water plus the substances dissolved and suspended in it. That's our plasma that floats around in our system, in our blood, in our arteries and veins. It's going to have all types of solutes in it, or different types of ions and material. It's going to have our glucose. It's going to have our proteins and food substances, our white blood cells, our red blood cells, our platelets, and different things in there that make it all of its viscosity or osmolality. So characteristics of fluid, we always look at the volume. Is our volume balanced, or is it too low or too high? Is the osmolality, or the amount of solutes in the volume, is it too high, too low, or is it normal? And then we also consider the pH. Is it an alkaline versus a balanced versus acidic fluid? Again, those electrolytes and substances that we'll be talking about, those are charged particles and ions. Sodium, potassium, calcium, magnesium. Pay attention to the abbreviations for those because sometimes we get our doctors and we get notes or someone will pass on saying the Na positive is too high or too low. You need to know what that means. K plus we use a lot for an abbreviation for potassium, and then calcium you'll either see Ca2 plus or you may see it just Ca plus plus, or magnesium plus plus. They'll have two pluses behind it indicating that's a magnesium level. All the body fluids that we have in our system have all types of electrolytes, and those electrolytes will move from either being within our system or being in the extracellular material or inside the cell or intracellular, depending on the concentrations, because remember, we have a number of different ways that fluids and ions and particles get moved between our cell membranes inside the cell and outside. One is, of course, osmosis, where water will move from a higher concentration to a lower concentration. We have diffusion, which is gases that move from higher to lower. And that's the process that they move. And then there's active transport, which is actually energy that is going to be expended in order to move an ion from inside or outside. So it's good to know all those terms and what they mean and where everything can that goes within our system. So our scope of attention for this particular lecture is looking at optimal balance or imbalance, looking at the fluids and electrolytes. We're going to be talking sodium and potassium, or sodium mostly in this particular. We're going to go through hyper and hypo sodium. And then our next lecture is going to cover the rest of these fluids and electrolytes. It's so important that you get this concept. So very important to watch these videos, to look at your SurePath, to make these readings, because this is the basis of what we're going to talk about, especially in third term with IV solutions and choosing the right IV solution, making sure we have the right one, because you need to know if a normal saline is normal, that means it's in balance. But if we are using hypotonic or hypertonic, you need to know what is going to happen when we administer that type of fluid to these patients, and whether or not it's going to be replacing fluid levels and ions, or is it going to be taking it out of their system. Giving the patient the wrong fluid is going to harm them. So this is the reason why I stress it is so important to know this. So take the time to learn, to listen, and to read as much as you possibly can. So with fluid and electrolytes, review Giddens, page 54. There are three physiological processes that create fluid and electrolyte balance. It's our absorption, distribution, and output. So depending on how we absorb, how we distribute it, and how much we're peeing out or how much we're sweating out, that's going to affect how we are optimally balanced. So intake and absorption of fluids and electrolytes match the output of fluid and electrolytes. We stay in balance. If we have volume and osmolality and electrolyte concentrations of fluid in the various body fluid compartments are within their normal range, we call that balance. So as you can see here in this diagram on your right, the optimal extracellular volume, optimal osmolality is going to be a sodium level that's normal. It's going to have an osmolality level that's 280 to 300 millimoles per kilogram. That's normal. And then our potassium has to be between 3.5 and 5.0. If it's too dilute, it's going to be too low. Too concentrated, these ions are going to be too high. So what do you think the most common route of intake is? How do we get fluid in our bodies the most easiest and normal way? Of course, it's the oral route. We actually drink our fluids. Now, other routes that we can also use is to give it by IV. We can use nasal gastric tubes, or we can use PEG tubes and G tubes, the infusion into subcutaneous tissues, or we can use an infusion process interosseous that we infuse it into the bone. If we can't get an IV access in an emergency situation, we'll actually take what we call an interosseous plug and actually put that into the tibia, into the bone marrow, which is a large bed for us to be able to infuse large amounts of fluid very quickly when we have an emergency. Fluid and electrolytes that enter the body by all routes except IV must be absorbed into the bloodstream because the IV goes directly to the bloodstream. IV fluids and electrolytes do not require absorption because they enter the bloodstream directly. So that's the reason why we don't have to worry about that. Distribution, that is the process of after we drink or after we have our IV fluid, those electrolytes enter the blood. They are distributed to different various body compartments. The process of filtration distributes the extracellular fluid between the two major areas called extracellular compartments, the vascular and the interstitial. Vascular is our blood. That's the plasma that floats around in our arteries and veins. Interstitial is the fluid that exists between our body organs and between our cells. The process of osmosis, and again, that's the movement of water, distributes water between the extracellular fluid and cells because of osmotic forces. So higher concentrations of solutes want to go to areas of lower concentrate. Our body always wants to be in balance. So remember that. That's an important concept to understand, that the body is always driven towards balance. And because of that, if we give a patient that is dehydrated, a large amount of electrolytes, then they're going to take those electrolytes in and it's going to distribute through their body because there's a higher amount going in that's going to evenly balance and go into the cell. But if we if we have too many electrolytes inside the cell, we can actually pull those out by giving a lower, like a 0.45 normal saline will actually pull fluid out of the cells. So that's going to be part of our distribution processes that we use. Output. What is the normal route of output? Urine. Yes, urine is the normal output. It's our kidneys, our feces, our sweat. When we breathe, especially with me doing the talking here, as I am talking, water vapor is leaving my body. I'm actually losing my water balance. And so that's the reason why we get thirsty, why when we're outside and we're running and we're sweating and changing those things with our body heat goes up, then we're having insensible water vapor, which is leaving our lungs and leaving our sweat pores. So we have to take in that account that as a patient has a high fever, it's going to increase their amount of fluids that they're losing. So their output's going to be higher. If you're working outside on a hot day and you're sweating, your output of fluids is higher. That's the reason why you can become dehydrated so quickly. And that's the reason why it's so important to be making sure that we're replacing those fluids. Other excretory routes in the insensible water range is through that skin and lungs. Remember, when you clean your glasses and you blow on them, you get that vapor. Well, that's water vapor coming from our lungs. So what is the abnormal routes of output? Again, that's that insensible loss through fever. Abnormal routes would also include emesis, hemorrhage, drainage through our tubes, fistulas, where we're losing uh, fluids through an opening from one side of our body to the other. These abnormal output routes do have physiological regulatory, they don't have the physiological regulatory mechanisms. If we have a wound or a person has been shot, or if they've been knifed, or if they've had an injury where they've fallen, then that volume output is not is an abnormal route of escape of that volume. So we need to consider those outputs. Again, I want to give you a better definition of insensible. Insensible means this is not something we actually sense. We don't think about this. We know about urine. We know about emesis. We know about diarrhea. But insensible water loss is the continuous unperceived evaporation from the body. Again, that's our respiratory tract. It's our sweat. It's contributing to our fluid loss up to 600 to 900 milliliters per day, almost a liter per day. And that can increase when we have a fever. Again, very important when we're taking care of very ill patients. So body fluid compartments, let's review this. We have the intravascular compartment that's inside our vascular system. That's our veins, our arteries, our capillaries. And then we have the intracellular compartment. The intracellular compartment is the space between our vascular and our cells. Excuse me, intracellular is the compartment inside the cells. I wish they had put this the other way on this particular screen because I always get that thrown in the wrong place. So intracellular, inside the cell, extracellular, outside the cell. So here we have a nice diagram that's showing the interstitial compartment, the extracellular compartment, and the vascular compartment together. So that makes our fluid distribution by osmosis. Fluid easily moves from one space to another and is pulled depending on how low the concentration is in another. So again, if our cells are overflowing, then it easily moves from inside the cell to the interstitial compartment. If the interstitial compartment is very high in water, then it will move into our vascular system. Okay, let's move on here. All right, movement of body fluids. This is where our video would come into play with cell membrane transport, diffusion, osmosis, oncotic pressure, and hydrostatic pressure. Please make sure that you review this. Again, I've embedded it in the PowerPoint. I will also share the URL, as you can see in my notes, if you have my notes up. We're discussing Saunders, page 85 to 86. And then I want you to look at this. It's about really and truly, you want to watch at least from the 4-minute mark to the 7:47 because it's going to discuss and explain osmosis of an active transport. So osmotic pressure, that's when a more concentrated solution is on one side of a permeable membrane and a less concentrated solution is on the other side. It pulls that water through that membrane to the side that has too little. Hydrostatic pressure, that's the force excreted by the weight of that solution. So that is the force that it's like water pushing out of a hose. It pushes fluid out of a blood vessel, capillaries into the tissues. And then active transport is an active transport system moves molecules or ions against that concentration and osmotic pressure, meaning that the body is trying to move it from a low concentrated area to a high concentrated. So that's active transport. And it has to have energy. It has to have ADP in order to move that. So we have to have energy to move sodium and potassium across the cell membrane and helps control where water goes by moving those solutes. Watch that video. I'm not going to show it here because I cannot get the sound where you can hear it. Okay, fluid balance. Please review Williams page 448. The patient may be unable to ingest food or liquids, and they may have a problem with absorption from the intestinal tract, or may have kidney impairment that affects excretion or reabsorption of water and electrolytes. So a healthy intake and output is necessary for us to be able to have that fluid balance. We have to balance what we take. In other words, what we take in has to go out, and what goes out has to be replaced. So healthy kidneys regulate that fluid and electrolyte balance by regulating the volume and composition of the extracellular fluid. when you have a disease or illness that impairs that work, such as circulation of the heart, like in heart failure, it can actually affect the distribution and composition of body fluids. So we can have a risk for electrolyte imbalances. As the slide is asking, can you name a few illnesses that interrupt fluid and electrolytes to cause a fluid imbalance? I've already mentioned one. That was heart failure. The other that we need to consider is a patient who has been a burn victim. Burns impair the skin. The skin is our first defense against infection, but it's also our defense against insensible water loss. It helps us maintain our balances. It protects us from losing too many fluids. When we burn the skin, the first thing that you notice that happens is that we'll get a blister, and blister is the movement of that water that forms over the skin to try to repair it. So those patients lose large amounts of body fluid, and then, of course, large wounds like gunshot wounds and knife wounds, or a patient who has fallen from a great and may have an open fracture, they're going to lose a lot of their fluid because through either the blood or through the opening and impairment of their skin. So very important to keep that in mind too with fluid balance. Fluid balance exists when the body has an excess or too much of water or a deficit too little of water, which is what we call dehydration. Water always will follow sodium. So if sodium is highly concentrated outside a cell, meaning there's a lot of sodium outside a cell and there's water within that cell, that's a lot, it's going to be pulled out of the cell into the water. It's going to shift. It's going to osmotically follow that sodium. If there's a lot of sodium inside the cell, then water will be pulled in from a higher concentration outside the cell to inside the cell. So again, that is, remember, sodium and water. Water always follows sodium. Fluid volume deficit, we talk about hypovolemia or low volume or dehydration. So who is at risk for this? If you need to, make sure that you review Giddens page 449 to review those risk areas. So we have our older adults, we have children. Children can lose their volume because that's so much lower than an adult. A small child, an infant, can lose and become dehydrated with a fever extremely quickly. That's why it's very important to replace fluids with small children, especially neonates. Clients unable to take in sufficient quantities of fluid will have maybe impaired swallowing. Maybe they'll have some type of weakness. They'll present with disorientation. If it gets severe, they can go into a coma. And if the patient is in a coma, they're going to have some water loss that we're not going to be able to see or sense due to the fact that their systems are not working at their optimum anyway. And then, of course, if a community has unpotable water or water that's not able to be drank, that those people are at risk. So clients who lose excessive amounts of fluid through prolonged vomiting, diarrhea, hemorrhage, diaphoresis, or excessive wound drainage are also at risk. So those are your risk areas. If I were to ask you to identify the patients who are at highest risk, look for those patients with vomiting, diarrhea, hemorrhage, diaphoresis, excessive wound drainage, or patients that have weakness or impaired swallowing. Our clinical cues, let's look at those. We want to keep an accurate record of the amount of drainage removed by section so that adequate fluid can be replaced. If we have a burn patient we're taking care of, to look at the drainage from the large wounds or fistulas, that which can deplete also the fluid volume. Accurate INOs are very important within the setting of intensive care or within a cardiac care, and also within our geriatric population. That's the reason why we want to make certain that we're making available water and drinks for our patients, offering them fluids every now and then. If a patient, again, falls, I want to remind you that when a patient falls, But the excretion of adrenaline and epinephrine because of the stress of the fall, they can become dehydrated. And maybe they have no other injury, but they'll be confused because they've become dehydrated after the fall. Make sure we're offering fluids to those patients. Make sure that they're getting something to drink. We don't have to get them up right away. Let's have them, if they're okay and they're talking with us, have a little bit of a drink and get their fluid levels back up, and then get them up, check their blood pressure, make sure everything is okay. When there is too little fluid in the plasma, fluid is drawn out of the cells by osmosis to equalize the concentration. Remember, I said that everything, your body always wants to get to a balance. And then if that plasma is high, it's going to shrink the cell. It's going to pull the solutes and the water out of the cell if there is a lot of solutes in that by osmosis. So, how does fluid volume deficit look? What are the things that we see with hypovolemia and dehydration? The first thing we'll notice is some signs and symptoms that they may be mild complaints of dizziness. The patient may be confused. Their skin may be cool or dry. Look at the urine. Is the urine looking like maple syrup? Is it dark? That indicates that they don't have enough volume. If they have decreased blood pressure, is their blood pressure 102 over 50, or is it 99 over 60? I mean, look at those blood pressure levels. Something is not right if that's not a normal blood pressure if the MAP or the mean arterial blood pressure is less than 65. Look at their lips. Are their lips dry? Are their tongue is the tongue cracked and looking dry, and it's not moist or red? Do they have an elevated temperature? Look at their veins when they're lying down. Is the neck veins flat? Do they have an increased pulse rate, poor skin turgor? Now, remember, on an older person, we're not going to check the skin turgor on the hand. A younger, yes, because they have good elasticity. But a older adult, we're going to check right around where the clavicle is, or around the shoulder area, right in the front of their neck, and we're going to pinch a little bit there. We're going to look at the skin in that area. If they have orthostatic hypotension, that's another thing to check. Remember, orthostatic hypotension is when their blood pressure drops by 20 millimeters of mercury when they stand, or when they go from a laying position to a sitting position. Do they have thick saliva? Are they thirsty? Now, remember, your older adult with dementia or Alzheimer's may not be able to express thirst. They may not know that they are thirsty, that we lose our ability to sense thirst as we get older. They may have a weak, thready pulse, and that's one of our signs and symptoms as well. They may have just plain weakness. They may not feel like getting up and moving around. So the treatment, easy. Remedy the underlying cause, replace those fluids. Either give them fluids orally or IV, and make sure that we get their balance back. Go do some blood work so we can check to see where their sodium, potassium, check the BUN and creatinine so we know that BUN, if it's elevated, that shows us that they may be dehydrated. If BUN is too low, then they're hypervolemic. That's why the blood urea nitrogen is so helpful. Again, here's a sign of checking. This is the forearm. If that would tent, then we might have some dehydration going on. Another video here on fluid volume deficit, hypovolemia, and dehydration. I'm not going to show this because it doesn't work on this particular, we can't hear it very well. So make sure that you listen to this, you go over this on your own. Okay, we're going to go to the next part of this. See if I can get it to move on. Okay. Fluid volume overload and hypervolemia. Who's at risk? Well, people who become ill may take in more water than they excrete, receive eye fluid too quickly. Tap water enemas may lead to electrolyte balance or introduce impurities or microorganisms into the system so that they can also mess up their balance. We need to persuade people to drink more fluids. If they are drinking more than they can excrete, then they're going to get volume overload. But if they're drinking the right amount, we want to replace that. Our number one sign and symptom for checking on balance of fluids, guess what? We can get them up on a scale and weigh them every day or weigh them at least once a week. Sometimes in the nursing facilities, we don't do that. We just kind of weigh them when they first arrive and we don't ever think about weighing them again. Uh, Probably a good idea to weigh these patients at least once a week. If they have heart failure, we should be doing it daily so that we can determine if they have fluid overload or if they're having fluid volume deficit. Yes, we can over treat our heart failure patients to the point where they also have fluid issues. If we have fluid volume overload, we're going to hear it in the lungs with crackles, or we may hear um, fluid around the heart when we're listening to the heart. We may hear a rub. If they have fluid volume, sometimes we talk about S1 and S2. S1 is the lub and S2 is the dub, but sometimes they can have a third heart sound in there, and that could indicate that they are in fluid overload. So, who is at risk? Of course, cardiac patients are at risk. Patients whose kidneys don't work very well are at risk. Patients who have diabetes or they may have overproduction of antidiuretic hormone that disrupts their ability to actually get rid of fluid. So they're going to end up conserving too much fluid and end up in fluid volume overload or hypervolemia. So we would be looking for weight gain, again, crackles in the lungs, slow bounding pulse, elevated blood pressure, opposite. So these are the opposites of fluid underload or volume underload or dehydration. Our overload is going to be elevated pulse pressure. Our volume dehydration was too low a blood pressure. And instead of having skin turgor, where their skin is not very tight and elastic, now we have edema. And we could have that volume in their abdomen with ascites. We could see it with ascites, and they may have pitting edema. So let's talk about edema. Make sure that you review page 450 in Giddens. It defines an excessive accumulation of interstitial fluid. It is often a sign of fluid overload, but it may be due to other causes. So we have, first of all, the dependent edema is edema that occurs in an extremity that is kept in a low position. Like, for instance, a person sitting in a chair too long will sometimes get swelling in their feet or swelling in their ankles and legs, and that's called dependent edema. That when they raise their legs up, now that edema shifts or that fluid shifts and it gets back to the center part of the body, and their swelling goes down. Then generalized edema is edema that's everywhere. It might be in the arms, it can be located in the face, the extremities. Sometimes you'll note that the person may have swelling around the eyeballs. Now, with dehydration, they can have sunken eyeballs, but with overload, they can have protruding and puffy eyes. We can also see that with especially a patient that is supine, that is not getting up, they're immobile, that if they have edema, they may have edema on the sacrum or on their back. It won't be in the legs. Look at whatever is the lowest part of the body. So when we turn them to help clean them up, we may note that they have some edema in their buttocks or in their sacral area. So then that would tell us they may have some fluid overload. So, diuretics. Let's talk about diuretics, the uses and the nursing implications. Our diuretics are used to take fluid out of the body. Of course, too much diuretics is not a good thing. Too little diuretics is not a good thing. If we're not getting the fluid, again, we want to make sure that we're keeping things in balance. And again, sometimes we can dry patients out if we give them too many. So that's one of the concerns that we have. So we need to be able to check that BMP or the CMP and look at the BUN and the creatinine once in a while to make sure that we're not overly drying these patients out, that we're keeping them there. Diuretics are wonderful in the use of heart failure or with kidneys that are not working very well because it helps us get rid of that excess fluid. So it does, I mean, they're good meds, but they can be overabused. So there's two major uses for those diuretics. One is for the cardiovascular system and to use in hypertension. So for heart failure and hypertension, that's really great. I mean, we use hydrochlorothiazide and Lasix and torsemide. Mannitol is a diuretic that we use to reduce cerebral edema or swelling in the brain. Acetazolamide reduces intraocular pressure with glaucoma. So very important for us to get that pressure down when we're concerned about glaucoma. Spironolactone, it's effective in reducing ascites associated with liver disease, but is also used in heart failure. It is a potassium sparing medication, so we don't have to worry about giving people extra potassium when we use it. Thiazide diuretics, especially hydrochlorothiazide, used for prevention of kidney stones or hypertension, may be added as a base to antihypertensives. You may see lisinopril that has hydrochlorothiazide or valsartan that has hydrochlorothiazide attached to it. And of course, we all know about furosemide or Lasix. We've talked about it quite often. It is a loop diuretic. It actually helps reduce fluid, but it also takes some potassium with it. So when we're giving furosemide or Lasix, we need to make sure that we're checking the potassium level and replacing potassium as needed. So we need a good assessment from our patient. We need to make sure that we understand what type of heart failure they've had or heart problems. Have they had a heart attack, heart failure, valvular disease? Do they have dysrhythmias? If they have liver issues, do they have ascites, cirrhosis, cancer of the liver, or renal failure? Other immobility problems, such as hypertension, pregnancy, and the use of corticosteroids. So our history would include the onset, duration, and progression of their symptoms. Do they have edema? Do they have bloating? Do they have difficulty or sleeping flat? Are they having to use some pillows? Because that may be telling us that they're having some fluid overload. They may have weakness and fatigue, and of course, shortness of breath. If they can't walk across the floor without having shortness of breath, they may have too much fluid on board, and that affects their heart and their lung uh, uh, function. So we don't want them to have those problems breathing and their heart functioning. They may have a history of a productive cough. Make sure that we are checking their weight. How's your weight been? You know, have you had a 2 pound increase or a 2 pound decrease? Again, 2 pounds may indicate that they've lost a liter of fluid. If they've had a weight loss of 2 pounds, 2 pounds increase is a liter of fluid that they have gained. We always ask our heart failure patients to notice that and to call us if they see that 2 to 3 pounds weight gain. If they have 5 pounds in a week, we definitely want to know that, especially if it's been a half a pound here, half a pound there, half a pound here over a week's time. That can really add up, and they can be slowly going into volume overload. Again, teaching them how to check their own skin turgor, to look at their tongue, to check their oral mucous membranes, and then to also do laboratory checks on their hematocrit and their hemoglobin, which will also tell us whether or not they have hematocrit will go down as they're dehydrated. It will go up if they're overflow, if their volume is overload. So their hematocrit will actually go up if they're in dehydration. It will go down if they're in volume overload because it gets also, the hematocrit gets, what is the word I'm looking for? Their hematocrit gets diluted. Thank you. BUN and creatinine, osmolality and electrolytes, all of that needs to be checked. And then, of course, overhydration, the increases in abdominal girth. They may find that their pants don't zip or they can't get the button buttoned on their pants. They've had weight gain. Have they had neck vein distension when they lay down flat? Is their jugular veins distending? Crackles in the lungs when you listen to them again, and electrolyte imbalance. So very important things to be assessing. When we're talking diuretics, they should we should be helping the patient determine when the best time it is to take those. Furosemide lasts in the system for about 8 hours. Torsemide will duration is around 10 hours, and sometimes we need to know how long these are lasting. We want to make sure that they're taking their diuretics first thing in the morning. We don't want them taking them late at night. A lot of times my patients, when I worked in congestive heart failure, would say, well, I don't take my diuretics if I'm having to go to the doctor because I don't want to pee all the time, or I worry about when I get in my vehicle that I'm going to have to urinate, because when I take it, it really hits me hard. And sometimes they'll plan on taking it later in the day. Um, then they're up all night is the bad thing I want to say about it. If they're taking it after 5 o'clock or after, and you've got an 8 hour duration, that means that Lasix is still acting on them at 1 or 2 o'clock in the morning. So the later they take it in the day, and if they're taking Lasix twice a day, then they should take the first dose when they get up in the morning and then a second dose earlier in the afternoon so that it's out of their system so they can sleep. We can help the patient choose the best times to take their medications if we review those medications and we look at how the medications work. We can basically give them a plan of how best to take these. They could use a medication schedule template where they learn which pills to take in the morning, which ones to take at noon, which is best in the evening before dinner or after dinner, and then what those right before bedtime. So those are very helpful things to help with their patients. When I worked again at the heart failure clinic, we would have our patients come in with all of their medications and herbs and everything over the counter. We said, put them in a grocery sack, bring them in. And then we would go over them and we would help them come up with a plan on how to best take those. We can instruct the patient then to also perform daily weights using the same scale with the same amount of clothing at the same time of day before breakfast, and to record any significant weight changes because weight gains or losses are the best indicator of fluid loss or gain. Again, 2 pounds in 2 days should be reported. 2 pounds overnight definitely should be reported because that's a liter of fluid that's gained. Potassium supplements can be prescribed with the diuretics, especially if it's loop diuretics like Lasix and torsemide, because we want to replace that. Those medications are quite large and hard to swallow. Sometimes we may need to consider whether or not they need a liquid potassium supplement. Diuretic therapy may also produce hypotension and dizziness. So it's very important for us to tell this patient before standing up, do some ankle pumps. Take a couple of good deep breaths in and out that kind of raises the blood pressure a little bit, then stand. If you feel dizzy, sit back down. Don't try to walk and be dizzy. Again, do some ankle pumps, move those legs up and down. Would tell my patients, reach for the sky with their arms on both sides 3 or 4 times and then stand up because then they're getting that blood pressure up so that they won't have the dizziness. And to also, again, make sure that they're drinking their fluids through the day. Even though they're on diuretics, we still need them to have some fluids. And they may be on fluid restrictions, which makes this a little bit more difficult, but then we can plan how they're going to dole that water out over the day so they don't feel like they're really badly thirsty. If they drink all their water in the morning, then there's nothing they can have at night, and then that can be very uncomfortable, and patients won't stick to that program. So again, here on the next page, we're talking loop therapy, loop diuretics, furosemide, torsemide. Those are the ones that take potassium out. Thiazides or hydrochlorothiazide are the ones that are added to our blood pressure medications. Those are a little bit milder. And then potassium sparing diuretics like spironolactone, aldactone, or pelnirone are those that actually help save potassium. If they're taking those, we need to make sure that we do some teaching to make sure that they're not using potassium chloride and increasing the amount of potassium. So we need to make sure that we're checking that. If these patients are on digitalis, very important to remember that low potassium levels can cause digitalis toxicity. So we want to make sure that we're checking potassium levels on those patients that are on digitalis or digoxin. Digoxin is used in heart failure. It helps with the heart cardiac output. If they're on corticosteroids like prednisone, potassium can enhance the loss of potassium. So check potassium levels with them as well, especially if they're on prednisone long term for COPD. Now, thiazides, those act on the distal tubule of the kidney and they block reabsorption of sodium. So, in those patients that are on those, we need to watch for sodium impairment. Is their sodium levels off? Go ahead and read through my notes if you want to there. It gives the entire reasoning and things that we should be watching for, especially with potassium sparing diuretics. And then obtaining a baseline of these patients so that we know what their lungs normally sound like, what their vital signs normally look like, what their laboratory studies. We should always do laboratory studies before starting any of these medications so that we know exactly where we're starting out, and then have them come back in 30 days so that they can make sure that we can see, okay, how is this affecting them? How is it changing their balance of their electrolytes? And then to also talk about to them about any issues that they're noting in their urination, sleeping. Are they having muscle twitching? Are they having any problems with libido? Men that are on spironolactone may report thickening or increased size of their breast. And so there are other drugs like apelnerone that we can put them on that does not have that particular effect. Women may complain of breast soreness and menstrual irregularities when they're on spironolactone, so we need to also assess that as well. And again, at the bottom of my note here, it says important, do not administer with potassium supplements or salt substitutes that are high in potassium because of the potential dangerous effect from hyperkalemia. Again, spironolactone, aldactone, allopurinol are going to save that potassium. They're not going to excrete that potassium. So those patients that are trying to do their best to not use sodium, they're going to end up needing to make sure that they're checking their potassium more often and reporting any muscle twitching or muscle cramping so that we are able to check that out. Here's another video that I'll have you watch on your own. Again, it doesn't work well with our platform here with the Zoom. This is hypervolemia fluid volume excess. Very important that you watch this. All I can say is just please watch this. My uh, lecture today is going to be much shorter because we're not watching these. Okay, measuring I and O's, what is included in intake, what is included with output take, how does the nurse evaluate whether there is a fluid imbalance? Okay, so we're going to be measuring everything that the patient drinks, any fluid consumed. That's going to be ice cream, sherbet, gelatin, soups, popsicles. Those things are considered fluids. We need to know that in between meal drinks, what's the patient drinking and what do the nurses give with medication pass? If you've got a patient that is getting their medication through an NG or a PEG tube, those boluses that we give at the beginning, the 30 mLs or the 60 mLs that we're giving before we start the med, and then we're giving 15 mLs. What I do is I actually will measure out in a cup the 240 mLs, and then I'll use that 240 ml cup to use as my bolus and to mix with my meds. And that way I can keep track of how much I'm giving this patient to put on my I's and O's. And then IV fluids, we want to make sure that we are measuring how much have they received. Are they getting antibiotics that are 50 mLs or 100 mLs that goes in on that intake? Then our other intake sources are going to be blood products, tube feedings, parental nutrition. We're recording all of that amounts in mLs and we're tracking that between meals. So make sure that we're tracking all of that. Remember, intake and outtake could be on this next test. Make sure that you know how to add that up. Where does it go? Which part is the intake? Which is part of the outtake? Output is our urine output. Bedpan urinal measurements can range anywhere between 1,000 mLs to 1,500 mLs. And then if we see a patient not urinating at least 720 mLs in 24 hours, which is 30 mLs per hour times 24, then we need to know that because they don't have good kidney output. Something's going on with their kidneys. Other losses that we should be recording in output is emesis, liquid diarrhea, NG tube drainage. If we're having to put this person on NG and we've got them on low intermittent suction, everything we collect in that canister, it needs to be taken as output. If they have chest tubes, wound drainage devices, suction devices, if they're profusely sweating, again, that insensible water loss from fever, from sweat, we need to assess that. Um, I've had patients where we've actually had to weigh the linen before and after so we could figure out how much water loss the patient had. That's a lot of hard work to have to do. Use graduated containers for measurement. Empty drainage bags at least once per shift. Measure at the eye level on a flat surface. And make sure to wear your gloves and using appropriate PPE when handling the output. Record totals for each shift, and then you're going to enter a 24 total on ins and out. And then we're going to be evaluating that and looking, are we in balance? Are we in a deficit? Are we giving them too much? Are they in excess, or are they again uh, in a loss for their eyes and nose? And again, looking at daily weight, skin turgor at the sternum, presence of edema, and their vital signs. Has their blood pressure changed? Has their mental clarity changed? Do they have puffy eyelids, swollen hands, weak, thready pulse? Then that's going to tell us that they have volume overload. If they have crackles, then that would tell us that they may be in volume overload. So we want to make sure that we're trending all that and looking at all that. Again, with daily weights, we want to make sure that we're teaching these patients and our unlicensed assisted personnel to make sure that they're weighing our patients properly at the same time each day. If they're usually going to weigh these patients before breakfast, they should do it before breakfast. If they weigh them normally after breakfast, then do it after breakfast. Don't change back and forth. Remind them that to use the same scale. Otherwise, the measurements are going to be different. Accurately measurement of weight gain and loss is impossible sometimes, especially because if we're doing this at different times using different scales. Also, if the patient is in a wheelchair, we should know the weight of the wheelchair. Don't change the wheelchair on that patient. Make sure that they're using the same wheelchair and wheelchair scale to be able to be weighed on, because that may change what we're seeing. We won't, if we have a 5 pound weight gain, is it because we changed the scale, or if we change the wheelchair, it may not be that the patient is in a fluid overload. And I can't assess that if we're not doing everything the same every day. So why should we listen to the lungs of older adult patients who are receiving IV fluids, even if they have no current lung problems such as COPD or heart failure? Well, again, that's so that we can make certain that we can tell if we're giving them too much fluid. Are we volume overloading them? If they suddenly have crackles and didn't have crackles earlier today, are we giving them too much fluid? So we need to be listening to that. That gives us a good idea of whether or not the fluid that we're providing them in an IV is too little or too much. Sodium, again, sodium serves several crucial functions in the body. It's impossible to have good nerve impulse transmission without sodium. Our muscles need to have sodium to contract. Fluid balance maintenance is important with sodium, and acid-base balance. Our blood volume regulation is also required with appropriate electrolyte or sodium base. Here's a good scale here for hyponatremia. That's too low of sodium. Again, too low of a sodium level. What is that level? Whoops. Let me go back here because that wasn't supposed to happen. Well, it still didn't supposed to happen. Let's see if we can get this thing to work. That's not going to work for me today. Okay, key points. Our sodium level, if it's below the normal, it's going to be less than 135. If it's too high, it's going to be above 145. I was trying to get my, still can't get it to click on there. Oh well. I had a nice little slick little diagram for you, but we'll look at that. So let's look at what causes hyponatremia. So make sure that you get this on a slide. Take the slide that I have here, and on the back of it, write down what causes hyponatremia and what the levels are so that you can have these memorized. Excessive diaphoresis, that meaning that they're sweating too much, can cause hyponatremia. Diuretics can pull out sodium out of our system. Kidney disease, because our kidneys don't function correctly, it may not save potassium or may force too much out. Inadequate sodium intake, meaning that we're not getting enough sodium in our diet, or will cause us to have low sodium levels. Excessive intake or retention of water. So if we dilute our system too much, we're over drinking, then we end up diluting our sodium. Loss of bile, which is rich in sodium because of fistulas and drainage, gastrointestinal surgery, and nausea and vomiting and suction. Loss of sodium through burn wounds. And then we also have dilution of sodium with the excessive ingestion of hypotonic fluids, irrigant, and hypotonic fluids. So again, uh, kidney disease, damage to the kidneys. Our kidneys cannot properly filter the excess water. This leads to water retention, and sodium levels remain the same. Um, if oh gosh, that's not very good a good way of putting this, but if we have too much water coming in and our sodium remains the same, it's going to dilute the sodium. So then our concentration becomes less in our blood and fluids. So many kidney disease patients may take medications that can affect their sodium balance, such as the diuretics we talked about earlier. And then there's a syndrome of inappropriate antidiuretic hormone secretion. Make sure you write this down, SIADH. Uh, when high blood sugar or glucose levels are high, it creates an osmotic effect and shift that moves water from inside the cell to outside the cell. And that dilutes the sodium, which causes a pseudo hyponatremia, meaning it's a fake low sodium, and it causes us to have an artificial dilution. And then, of course, heart failure. Heart failure then causes so many different things, including sometimes low sodium. So hyponatremia, again, looking at hyponatremia serum, again, is less than 135. Know your signs and symptoms. What are our nursing interventions? Remember the signs and symptoms by using this mnemonic, if this helps. So it's called salt loss. Um, when we see a patient with stupor or coma, they may have hyponatremia, anorexia, nausea, vomiting, lethargy. If we look at the tendon reflexes, they're going to be low. They're going to be limp. The muscles will be weak. Orthostatic hypotension. These patients may have seizures. They may complain of headache. An older patient that complains of headache is primary, gives you a good sign that maybe their sodium is too low. And then, of course, stomach cramping. Hypernatremia, we're switching now. Let's talk about hypernatremia. This is going to be too high of sodium, too high of sodium content, greater than 145. So what causes hypernatremia? Well, causes can be decreased sodium excretion, meaning that they're not excreting enough sodium out of the kidneys, and that can be corticosteroids like prednisone increases sodium retention in the renal tubule. Osmotic diuretics like mannitol, they have electrolyte loss, which is greater, and the water loss is greater than water loss relative to sodium, meaning that we end up with a electrolyte loss that causes us to hold on to the sodium. If our kidneys are damaged and the nephrons can't respond correctly to antidiuretic hormone, it may cause us to excrete too much we may be urinating too much out, and then our sodium levels inside our body will actually, um, because of dehydration, will actually increase. Hyperaldosterone creates sodium retention beyond water retention, and excessive oral sodium ingestion, meaning they eat too much salt and salt-containing foods. If we are giving too high a sodium concentration in IV fluids, which causes a lot of issues. And then decreased water intake, meaning the person is fasting. They're not taking anything by mouth because they're in PO. Or if they're mentally confused, they're not drinking enough during the day, so their sodium levels go up. If we are administering high protein, hyperosmotic tube feedings, that can also cause hypernatremia. So increased water loss from increased rate of metabolism, fever, hyperventilation, infection, excessive diaphoresis, watery diarrhea, and also diabetes insipidus. Remember, diabetes insipidus is the condition where the person is peeing and peeing and peeing. It's very dilute urine, almost completely white. I mean, or clear. It looks like water. And when they have that type of urine output, they're dehydrating themselves, and their sodium and ions will actually increase. So all of their ions increase. And we need to be able to assess that. So remember that volemic hypernatremia, that means that low volume, high sodium is caused by things like severe diarrhea, excessive sweating, vomiting, bad burns where it's affecting quite a bit of our surface of our body, inadequate fluid replacement, and too much mannitol administration or mannitol administration itself to get rid of our swelling of our brain. So again, here's hypernatremia again. It's losing more water than sodium, gaining more sodium than water. Either way, um, it could cause hypernatremia. So what are our signs and symptoms again? It could be bounding pulse, increased blood pressure, distended neck veins, weight gain if they have hypervolemic issues. If they have hypovolemia, then it's tachycardia, postural hypertension, flat neck veins when supine, and decreased blood pressure. So we have two different things going on here. One where we're losing more water than sodium, and it causes a reduction in volume, and our sodium is too high. Then we have one where we're gaining more sodium than water, where the sodium is going where it's not supposed to. So with respiratory, we can have pulmonary edema if hypervolemia is present, too much fluid. Neuromuscular, early spontaneous, we can see muscle twitching, irregular muscle contractions. Late symptom is skeletal muscle weakness, and deep tendon reflexes are diminished or absent. And then with central nervous system, we'll see altered cerebral function as their most common manifestation. The patient will be agitated, confused. They may have seizures. They may have lethargy, stupor, and coma. And in patients with GI issues, they'll have extreme thirst. If they have kidney diseases, they're going to have decreased urinary output. And they're going to have an increased antidiuretic hormone secretion, which causes water retention to normalize the sodium levels. So our body, again, is always trying to normalize itself. So it will try to secrete ADH when it needs to hold on to fluid and increase our fluid levels. Our patients will have dry, sticky tongues and mucous membranes. They may have dry, flesh skin. They will have a presence or absence of edema, depending on whether it's fluid volume overload or fluid volume loss. So we need to remember which one we're seeing. Make sure we're looking at those labs and to make sure that we're measuring intake and output and monitoring temperature. If we are having to treat a patient for those seizures, we need to make certain that we have seizure precautions and that we're safely recording their symptoms of postural hypotension or the drop of their blood pressure. Okay, next lecture will complete our discussion on electrolytes and fluids. We'll be covering hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia, and the magnesium will be reviewing both high and low. Make sure you're reviewing Clayton chapters 28, Giddens chapter 6, Saunders chapter 8, Williams sodium page on page 450, that you're looking at the daily weights on 458 and electrolyte chapters. Review these videos. I'm going to tell you, I'm going to stress right now, those videos will help you understand this material because it's hard to explain this material. It's a very difficult concept to grasp. If you're not understanding the material I provided, go back and look at Nurse Sarah's explanation of these items and go over those videos a number of times. Make sure you're taking good notes. Thank you so much for your time. I'm giving you some time back. Usually our lecture is an hour and a half. I'm right now at an hour and 9 minutes, so make sure to look at those videos to fill out the rest of your lecture time. Take care. Have a great day.